Hi there, I'm Dr. Martin Benfield, I'm a GP trainer, and this video describes how to write a clinical case review that will show off good capabilities in data analysis and making a diagnosis. It should also help you with improving your differential diagnosis assessment ability. The aim of this is to demonstrate your thinking in terms of the differential diagnosis list throughout the process of consulting with a patient. Two main outcomes will be clearly show your educational supervisor and the panel that you consider an initial wide range of diagnoses, then can reduce these down by analysing the evidence. Second would be self-analysis of your diagnostic skills to improve your ability to arrive at the most likely diagnosis, and so improving your consulting, your ability to pass the AKT and the SCA exams. If you've not watched it already, please watch the video How to Write a Clinical Case Review. If you have watched that, then you know keep the brief description brief. Usually, what did you know before you saw the patient? And write the information about the case under 3 capabilities in time order so that the reader can follow the story. So this is an exercise to try and writing a clinical case review where making the diagnosis is the main focus. Depending on the case, you'd usually use making the diagnosis capability, and the other 2 would be from data gathering and analysis, examination skills, if there were abnormalities that changed your diagnosis from the examination, and medical complexity is a good one to choose as well. When we consult with patients, we should have a list of possible diagnoses swirling in our minds from the moment the patient starts talking. As the patient explains their presenting complaint, new diagnoses appear in our minds and others might drop off. And overall, the order of the probability of diagnosis should be changing depending on the evidence being provided to us. This process should continue at all times. Never accept that the diagnosis is 100% certain. Always have a critical thought process. What else might be going on? Remember that only the patient knows the answers. So let the patient tell their story as fully as they can. Asking them what they think with ICE questions, and if there's an answer, asking why, will uncover useful information. Look out for the crucial bits of data that need to be clarified, such as the timeline of the symptoms and really important symptoms like dizziness. After the presenting complaint has been revealed, we have our differential diagnosis list in our head, and we now need to be thinking, what's the crucial bits of information that I don't yet know that will decide between these different diagnoses? And that will then enable us to choose what tests do I need to do, what treatments are going to be the best ones to offer. Next in our writing of in the clinical case review would be the examination. This may change our diagnosis list. Following from this, we may arrange tests. In hospital, tests are usually returning within an hour or 2 maybe. In GP, it could take weeks or longer. When these results return, the diagnosis list may change again. The next stage is treatment. The response to treatment can change our differential diagnosis list as well. In hospital, treatments often start after the results have returned, whereas in GP, we will often start a treatment initially while still arranging tests, so before the results are back. At each of these stages, new evidence might change the differential diagnosis list order. And so depending on your case, you can have that within your write-up. When considering your differential diagnosis list, remember that other than certain test results, there is rarely ever a reason to rule out a diagnosis completely. More likely, it will just change the probability order. So for example, not having a cough makes pneumonia less likely, but it doesn't rule it out. A female with obvious cystitis symptoms but a negative dipstick test still has around a 70% chance of having a UTI. The aim with writing under the capabilities is to write your differential diagnosis list and demonstrate how each piece of evidence contributes to the probability of that diagnosis list. It is up to you how you write it. One way would be to repeat this process 2 or 3 times. So what you could do is under data gathering and interpretation, write your differential diagnosis list out and write the reasons for the list after the history stage. If there's been examination findings of importance, then under examination skills, describe what examination you did, what were the findings, and how that changed the diagnosis list. If the examination didn't change anything, then include that information under the data gathering capability. You can repeat this process again under making a diagnosis after test results have come back, if that changed the order. If you feel 2 capabilities are appropriate for the differential diagnosis list description, then make your 3rd capability medical complexity, to write how you explain the uncertainty to the patient. How did you get across what was happening? For your learning needs, in this kind of case, you could do some learning into any of the conditions on your differential diagnosis list to learn more about that condition. And then under your reflection, you've done the learning first, then you write how your list and analysis would be different if faced with a similar situation next time, now that you have this additional knowledge. What information might you have asked for to help understand the list better? Was there any other diagnosis you should have considered? Are there any other examinations or tests you could have done? So I've written a clinical case review about a red eye as an example. This is to demonstrate how to write a clinical case review. It's not the nice guidelines on how to deal with a red eye. So in the brief description, I've got a 64-year-old man presented with a red eye that had started the day before. Then I've made my first capability, making a diagnosis. Below are all the causes of a red eye I could think of at the time of seeing the patient, in order of what I thought was an approximate prevalence rate. Possible causes of a red eye: bacterial conjunctivitis, viral conjunctivitis, allergic conjunctivitis, conjunctival hemorrhage, keratitis, corneal ulcer, acute glaucoma, ophthalmic herpes. There was no itching and A to B history, so I dropped allergy down the list. It was a little uncomfortable, but not painful, and no other spots, so I dropped herpes and an ulcer down. Conjunctival hemorrhages aren't painful, and no trauma, rubbing history, so I dropped that down. There was no discharge, so I dropped bacterial conjunctivitis below viral. It was bilateral, so this made an ulcer, hemorrhage, and herpes less likely. There was no past history of glaucoma, and also the patient described this discomfort as on the outside rather than a deep pain. Although he had not had his eyes checked for 2 years, so his pressures might be high without a diagnosis being known. He does wear contact lenses, so keratitis is a possibility. There was no foreign body risks that he recorded, and no trauma, so trauma and ulcer seemed less likely. And then I chose examination skills as my next capability. There was general conjunctival injection bilaterally with watering, but with no discharge, so I felt viral seemed more likely than bacterial conjunctivitis. Pupils are equal and reactive to light with normal retina. The disc looked normal, so acute glaucoma seemed less likely. No evidence of herpes, no foreign body seen, and it was not a conjunctival hemorrhage, so I removed that from the list. I applied fluorescein dye and found no evidence of an ulcer. And then I've gone to medical complexity as my 3rd capability. I advised the patient that I felt a viral conjunctivitis was the most likely cause, as this is the most common cause of redness in both eyes without discharge, itching, or a history of trauma. However, I explained that because he uses contact lenses, keratitis is possible. I did not trust my equipment to say there was no corneal damage at all, and not treating this properly could cause scarring, so therefore I recommended I refer him to the emergency eye clinic to rule this out. I also explained that an alternative option would be to use lubricating drops or give antibiotic drops, and attending the emergency department if at any time the symptoms worsen or no better after 2 days. As it was Friday, the patient decided to go to the eye clinic now rather than risking it getting worse over the weekend. And now I've go to learning needs. And under learning needs I've written, I did not remember to consider episcleritis and iritis in my differential diagnosis list. Therefore, I will read up on these topics and causes of red eye to reassess my differential diagnosis list. I've then gone away and done my learning, and under reflection I've written, having read up on the causes of red eye, Acute glaucoma can cause a dilated, misshapen pupil. I will need to look out for this on examination in the future. When I used the ophthalmoscope, I didn't specifically ask if there was any photophobia. This is more likely with episcleritis, uveitis, ulcers and keratitis. Episcleritis is more likely to be segmental rather than the whole eye. It can also be associated with conditions such as connective tissue disorders. The patient said his vision was okay, but I didn't formally check this with the Snellen chart. I should consider this in the future. Okay, that's my clinical case review. So try and have a go with this if you can. In the next few weeks, see if you can have a go with a couple of clinical case reviews using this kind of format. And if you find it useful, then please use this in the future for similar types of logs. Good luck.